بسم الله والصلاة والسلام على سيدنا رسول الله. اللهم صل وسلم وزد وبارك على سيدنا الحبيب المصطفى وعلى آله وصحبه ومن والاه. اللهم انفعنا بما علمتنا وعلمنا ما ينفعنا واغفر لنا وللسامعين والحاضرين يا أرحم الراحمين يا رب. السلام عليكم ورحمة الله وبركاته. How are you everybody? This is me, Dr. Ibrahim Halani, cardiac anesthesia consultant. I'd like to welcome you all to our current meeting. Inshallah, last time we were speaking about weaning of cardiopulmonary bypass, okay? And of course, we spoke a little about the pharmacological support we will need during the weaning, okay? And it came to my mind that I would do a complete separate session. This session, we will go through different types of inotropes, okay? Just to make you more familiar with the types of inotropes that we are using in cardiac anesthesia and how to choose the proper one for your patient. First, I wanted to tell you something. When I say inotrope, means I am acting on myocardial contractility. Okay, so this is not the only parameter I am working on for the cardiac output. Cardiac output, just 1 second. Cardiac output is stroke volume multiplied by heart rate. And the stroke volume, okay, is a combination or a result of the preload and the contractility. Okay. So we have the preload, we have the contractility, we have the heart rate. And after, we have the afterload. And this afterload, if we are speaking systematic, so it is the systemic vascular resistance. And if we are speaking about the RV side, it's the pulmonary vascular resistance. Okay. As you see, there is many items to be covered, like contractility, the preload, the heart rate, the afterload, BVR, SVR. So when you speak, this is, as I always say in my lectures, you have a fixed false old beliefs. I need to dismantle it, demolish it completely, and build a new, also false beliefs. Okay. So the old false belief is when you say inotropes, you can say anything that inotropes is relating to all of these. But the new false beliefs I want you to understand is we have inotropes and we have chronotropes, something that will affect the heart rate, and we have vasopressors, and these vasopressors will have their effect on the SVR or BVR, whatever. Okay. So now, cardiac anesthetist, I want you to have this old belief that phenylephrine, for example, is a inotrope. No, I want you to crush this idea in your brain and build a new idea that what is this drug? Is it an inotrope? Okay. So inotropes mean it will affect the contractility. So what is its effect on the BVR or SVR? Does it have a vasopressor effect? Does it have a chronotropic effect? All of these must be individualized. Okay, there is no one answer fits all or one size fits all. This point is clear. Let's say go on. Bismillah. So, mechanism of the inotropes. Positive inotropic support means increase myocardial contractility by increase the intracellular calcium in the myocyte. More calcium, more stronger contraction. Very simple, very straightforward. Okay, the mechanism is different, and we will see later what is the different mechanism. But this is more related to pharmacology and to physiology, so I will not expand upon it a lot, but I just will give you an idea to understand what's the difference between each type. As we just said, physiological effect overview. Okay, the preload may increase, may stay unchanged. Contractility is the primary effect; it's always increasing. Heart rate usually effect is increase, especially with beta agonists. SVR may decrease, may increase. VVR may decrease, may decrease, may increase. Okay? Fine. The other thing, when choosing introns, compare their impact on the preload, on the contractility, the heart rate, SVR, BVR, and tailor selection is based upon the patient hemodynamic profile. So it's your patient who will ask for his own support. Again, your patient condition or hemodynamics is what is asking for the support. Is it clear? How? We will see them. But also, what is the ideal inotropic agent? Theoretically, it has good contractility, as we said, and good ventricular ejection, either right side or left side, without increasing the heart rate or the systemic vascular resistance or myocardial consumption. Okay, it's just pure contractility. Okay, but in reality, that's not happen. There is nothing that affects only the contractility. Every drug that affects the contractility have other effects like vasodilatation, vasopressor, chronotropic, whatever. Okay, fine. What is the best? Which is the best inotropic support? There is lack of strong evidence to the superiority of a specific inotrope during weaning. Most available data focus on improving both cardiopulmonary bypass hemodynamics. No comparison on direct or long term. So if you say, for example, I wanted to win with W and what we say, W and noradrenaline. Yeah, your choice is W plus NOR. Okay. Another one is no, I prefer AB. Some also physiological drug. Okay, whatever. Somebody say no, 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 I prefer melerinone plus vasopressin. Okay, so your call. So far we don't have one that is superior to the other, generally speaking. But as I just tell you, you are tackling or affecting or dealing with some points, okay, like SVR, BVR, heart rate, whatever. So choose whatever you like, but target these items and keep the patient hemodynamically stable. Okay. Of course, there are some points in which the one will be preferred because of its effect. That, for example, you need, your patient has an RV failure or your patient has vasodilatation. Don't use something that causes vasodilatation. Okay. Clinical implication. Okay. Inotropes and vasopressors should be individualized to each patient. Okay, guided by TEE, hemodynamic monitoring, respond to therapy, use the lowest effect dose to avoid the tachyarrhythmia and the excessive myocardial demand. Okay, so far I have crushed some ideas in your memories and we built a new concept. We want to have it in our mind while we are going through. Now I have this table for you to go with me rapidly through different types of drugs of inotropes. Here I arranged it by this one here is the most common we are using. Number one is epinephrine. Okay. And as you see, epinephrine, we can use it in low doses, 0.01 up to 0.05 mic per kg per minute. Here you have a good small alpha and predominantly beta 1 and beta 2. Okay. Contractility and heart rate. So it has mixed effect, goes for arrest and anaphylaxis and all these nonsense. Okay. But if you increase it, the epinephrine, then it will go over the alpha 1. This is the vasoconstricting effect. Okay. So if you want to get benefit of the only beta effect of the epinephrine, yeah, SVR is good. I don't want to increase it. I don't want to increase the demand of oxygen. So I will go to low dose epinephrine because I know if I increase it more than 0.05 or some box say more than 0.1 mic per kg, the alpha effect will be predominant. And at this time, more vasoconstriction, more SVR, more oxygen, more strain on the LV. Okay. I hope this one is clear. Then our beloved norepinephrine. It used to have a very bad reputation in the 90s and the 20s, but it's gaining its all acceptance in the practice with the survival campaign, and its effect began to be yeah, accepted. Because earlier, when we first, maybe 20 years ago, they use, if you start noradrenaline for a patient, this means patient is harban totally. Okay, now no, we can use it and titrate it, and its effect is very nice. As you see, it's mainly alpha. It's a strong vasopressor. Okay, that's why it's used in septic shock. But as you see, it also has some beta one effect on the heart. Okay, so it's not it's not what we can say pure vasoconstriction. Like what? Go down here. You see this beautiful gentleman here, phenylephrine. See, it has all the effects here, but no beta, pure alpha agonist. Okay, it increases the SVR, and it has a reflect bradycardia. Okay, fine. Then our coming gentleman is dobutamine. As you see, dobutamine is beta 1 mainly, pure electron. But it has some mild vasodilatation, and that's why we call it inodilator. Who else have this inodilator effect or vasodilator effect? The isoprenaline. As you see, it has a good inotropic effect. Okay, but its effect on the heart rate is very prominent. Okay, clear so far? Fine. Usually we are combining these one together because as you see, they are both good beta, but isoprenaline, okay, has a potent effect on the heart rate that we don't have it that much on dobutamine. Dopamine, as you see, all this, it's a historical drug, for God's sake. And most of the time, nobody's using it except the cardiologists. They love it. And they love it in high dose. As you see, if the patient is in critical or whatever, they don't want to go for combinations. They go on high dose dopamine, high alpha, high beta, high D, high everything. Okay, just to keep the heart beat. Okay. But for us, an anesthesia, its role is very extremely limited now. Okay. Most of you, especially if you are working in the adult side, general side, you know the ephedrine. It's a well nice drug. Okay, indirect vasomimetic. The temporary increases the blood pressure. Okay. So far, I just want to give you some hint, and don't worry, we will go through each and individual drug of these while we are going. Okay, so this is the points I want you to understand. When I say dobutamine, it's inotrope more than vasopressor. When I say noradrenaline, it's vasopressor more than inotrope. Dopamine, dose dependent. Isoprenaline, pure beta. Phenyl, pure vasoconstrictor. So this is the idea I want you to get in your mind. The other thing I want to share with you here, this is a very nice arrangement. I have arranged all these drugs here by its vasoconstriction ability. As you see, phenylephrine and vasopressin are very, very potent, very strong, even stronger than noradrenaline. Okay, but they don't have any effect on the heart, while noradrenaline might have some or mild effect. Then we go to the masterpiece epinephrine. Okay, as you see here, epinephrine in high dose, as we just said, and the epinephrine in low dose. It's mainly high dose alpha, so it has a strong entropy, but also strong vasoconstriction. Of course, less than noradrenaline. But what about the low one? It has mild vasodilator effect even. That's why we love it. Okay, and the moderate effect on the heart. Okay, so low dose, it's good. It's almost like the butamine. Okay, I will show you the butamine. See, and here the butamine you'll find is that its effect is, and in this one we can say moderate to even strong. Yani 0.05 adrenaline is a strong dose. Okay, but here he's confined to the idea that low dose is up to 0.05. If you increase it to 0.1, I think it will be also strong. So low dose adrenaline is almost like the butamine, mild vasodilation and strong contractility. Okay. While our beloved isobrenalin, sorry, for the isobrenalin, as you see, it's vasodilator and strong. But mainly we are using it for two things: increase the heart rate and decrease the SVR, and or predominantly the BVR. It's pulmonary vasodilator. Of course, I will not speak about dopamine. Okay. And levosimendan does not have any role for us intraoperative. Then milrinone. Milrinone, as you see, it's also has a vasodilator effect and strong contractility. So those like low dose epinephrine, dobutamine, milrinone, isobrenalin, all of these are mainly strong, okay, inotropes, right? With vasodilator effect, but adrenaline, you might be happy to have is vasoconstrictor effect. While phenyl, vasopressin, or adrenaline are mainly vasoconstrictor with minimal cardiac inotropic effect. See, I'm repeating it because I want you by the end of this lecture to be familiar with all the drugs I have mentioned. Okay? Right, now let's go to see them one by one. Mechanism of action. Masterpiece of adrenaline. Okay? Receptor profile. Both alpha, beta, beta 2, whatever. Low dose, mainly beta 1, dominant, good contractility heart rate. High dose, alpha dominant, vasoconstriction. Well, I should now open the voice and ask you, but I will not. Yeah. Otherwise, some of you will have tachycardia already. So as you see, it will affect the preload. It will affect the contractility. Very nice. Heart rate, SVR, BVR. So theoretically, if I have a patient with pulmonary hypertension, I no need to go for adrenaline. Even if you need something, go for something that will not have this effect on the BVR. It will decrease the BVR a little bit. Which one? We will say afterward. But just keep this diagram in your mind. Okay, can you use it as a bolus? Definitely. Usually you prepare your syringe, okay, to have a 5 mic per mil. Okay. This is the standard syringe. You can give 5 mils, 10 mic, okay, and 1 mil by 1 mil titrate. In a rest, of course, it's 1 milligram. Then for infusion, usually we start with 0.01, zero 0.02, zero 0.02, and increase up to 0.3. And by the way, this 0.3 is different from center to center. Some centers say keep it 0.25, don't increase, and start searching for other things. I've seen some centers say no, up to 0.5 you can increase. So follow the protocol of your institute. Okay. Can you put it in the intratracheal tube? Yes, emergency if you don't have, the same as the IV bolus. Okay. 5-10 miles. Pharmacokinetics. It will function from almost than 1 minute. Okay, and the duration is they say 4 minutes. Metabolism, and excreted mostly unchanged. Will I use it both by bus? Definitely to improve the cardiac output by improving the contractility and also by improving the heart rate. So if my patient has bradycardia, sinus brady, his heart rate is 40s and his ejection fraction is low, so I will start adrenaline for him. You will have these 40s will become 60s or 70s, okay, and then ejection fraction improved also to be moderate, for example. Then you choose the right drug for the right patient. Can I use this in anaphylaxis? Of course, bronchodilation, mucus cell vasoconstriction, muscle stabilization, and then the rest they are using it also, and local anesthesia toxicity. Also, severe bradycardic hypotension, the one we just mentioned. If I have acute RV failure or severe asthmatic attack, sometimes even your patient has high اسمه ايه ده؟ Somebody always, sometimes your patient might have bronchial asthma during your anesthesia. Okay, so you can also give him adrenaline, or if has anaphylaxis during the antibiotic or something. Usually, most of the time, we're using vanco. Sometimes the vancomycin in some patients cause anaphylaxis. And at this time, some patients you will need to start adrenaline and give all the anaphylaxis things even to tackle this problem. What is the advantage? Rapid onset, short duration, easily titration, predictable. This is very important. You know, you increase it, the effect increase. No absolute contraindication, no reflexive vagal tone. Okay, that it will cause any abnormal tachycardia of the. So far it's excellent. No, it will increase the myocardial demand, ischemia, high dose hepatic alpha 1, risk of renal, mesenteric, peripheral, limb ischemia. Always keep it in your mind. High dose alpha, risk of renal, mesenteric, peripheral, limb ischemia. Okay? Because we will say this one a lot later on. Okay? High serum, high glucose, of course, may worse LV out flow tract, and this is what we call the HOCM patient or patient with a huge septum. We will say it also, and avoid with beta blockers because now you are giving drug, noradrenaline. It's positive alpha and positive, okay, beta. Then you give beta blocker. So it will abolish this effect, and this one will be the predominant. So what you did, very nice. Okay, fine. His brother-in-law, Mr. Noradrenaline or Levofed. As we say, it's potent alpha 1, alpha 2, beta 1 agonist or minimal beta 2. Alpha 1, it will give you a very good arteriolar contraction, vasoconstriction. Mild increase in contractility. Sometimes it has this effect. If you give a good bolus, you'll find that pressure raised up to 180s, 190s, and the heart rate will decrease to 40s. So take care, titrate, because it has a good effect on decreasing the heart rate. Here, I put it for you that you remember that this is number 1, number 2, number 3. And this one is a direct effect, but it will also decrease as a reflex. And BVR, as you see, also it has not the optimal effect. Although there I've read some papers, they are saying that some patient will have decrease in the BVR with noradrenaline, which is very strange, by the way. But they have said this may be due to increase or improvement in the mean pressure, and this mean pressure improves the coronary circulation to the right side, and this is the cause of improve or decrease the BVR. I have read it, so I'm just telling you. But as text, book based, no. Okay. You are using as a bolus, same like adrenaline, 4 to 8 or to 10 mics, and the continuous support. Usually, as you see, they are allowing it for high doses because sometimes it's your savior for patient with valvoplegia. Okay. Onset and all of these are the same. So I'm using it in septic shock, in the ICU, vasoplegia, we will speak about later in this lecture, inshallah, ACE inhibitor and ARP also associated hypotension. Like the patient you are receiving in the morning and he took his angiotensin receptor blocker or the ACE tablet in the morning. Usually this patient will have a significant hypotension with induction. You can use noradrenaline. And in hypovolemia, we are using it as bridge until you give the volume. Advantage, rapid onset. We all know, short duration, easily titration. Beta 1 inotropy will help a little bit. Redistribution of the blood to good organs like brain and heart. Superior to phenylephrine in some refractory vasoplegia cases. Okay, and you will see sometimes you are giving a phenyl to some patient and the boluses, and they will not improve. So we go for noradrenaline bonus. Risk of end organ, increase in afterload ischemia, increase in BVR, can precipitate coronary vasospasm. See, it's the opposite from the last paper I was telling you about. High incidence of fibrillation than vasopressin, and worse outcome post bypass than vasopressin in some studies. Okay, this is about vasoplegia, and we will speak about it. Then our beloved dobutamine. It's a synthetic drug, selective beta 1, increased cardiac output, okay, or mild vasodilatation due to beta 2 activity. So it's mainly contractility, some on heart rate, decreases CVR, decreases BVR, never used as a bolus, we are starting it from 2 to 5, sometimes they increase to 7 mic. After this, it will be a huge vasodilation from 7 to 20. Okay, so usually try to use it in this area. Otherwise, it will have a significant vasodilated effect. Same scenario in for the pharmacokinetics. We are using it in the post-operative after epinephrine when anesthesia vasodilation wearing off. This is on the OR or in the ICU. Cardiogenic shock, especially if the patient had high SVR, you can use it. But if the SVR is low, usually we are using it with noradrenaline. It's short acting, easy titrate, decrease the afterload, which is night, filling pressure is better, less tachy, less hypotension than isoproterenol, less tachy. يعني the three brothers we're speaking about is dobutamine, isoprenaline, and milrinone, and we will see every one of them has different characteristics. Better than dopamine, of course, for increasing cardiac index. Increase myocardial demand also. It might worsen the ischemia, especially if became tachycardia. Pro-arrhythmic, which is also because it has a high increased heart rate. No survival benefit. Okay. And hypotension risk if you are using it in a huge dose with anesthesia vasodilator. Dobutamine required vasopressor support preoperatively due to beta 2 mediated vasodilatation. Synergetic hypotensive effect with general anesthesia. This is the one I was telling you about. If you're gonna use it, especially in anesthetized patient, you will need a vasopressor. Usually, we start with them noradrenaline, especially if the dobutamine is in high dose. Isoprenaline, his brother, the brother of dobutamine, but mainly for heart rate, mainly for decrease the BVR. Okay, يعني isoprenaline, keep it in your mind, is that we are using it, yes, for contractility, but mainly increase heart rate and mainly decrease the BVR. Titration is the effect, same, 0.01 up, zero point 0.2, same pharmacokinetics. So we are using it, as I told you, as refractory bradycardia for basing until you put the basing. In the EB labs, they are using it to induce the arrhythmia. Usually they have their own isoprenaline line. Okay, advantage, short acting, and as I told you, chronotropic. Okay, and for the EB lab, disadvantage, tachycardia means oxygen demand, means ischemia, pro-arrhythmogenic, definitely, and it's very expensive and limited. That's why it's reserved for diagnostic and rescue situation. Sometimes not routine. يعني sometimes you have a patient who came by after bypass and his heart rate is he's on the brady side, and you start adrenaline, you start Dobio, and there is no good effect. Sometimes you give him small boluses of uh, isoprenaline to help with the heart rate. Dopamine, I told you, low dose, high dose, all this nonsense. Okay, rarely used now, as I told you. Usually the cardiogenic using it with high doses. High mortality, inferior to the vitamin, no proven neither. Pro-arrhythmogenic, reduce ventilatory response to hypoxia, extravasation, cause skin necrosis. يعني it's not a good drug at all. And yeah, there was some history about it's better to lose the low doses to improve the renal performance. And all of these have not been proven by any research. The third one, dobutamine, isoprenaline, and Mr. Milrinone. This one is a little bit different in the mechanism. It's phosphodiesterase inhibitor. I'll tell you something. If this is the cell, we have here outer cell, the adrenergic receptors, so alpha, beta, whatever, adrenaline, noradrenaline, all of these catecholamines came here to stimulate this receptor. This receptor will increase cyclic AMP signal. So it's increasing the cyclic AMP, and when cyclic AMP increases, it's increase the calcium. The milrinone has a different one. What it is? Cyclic AMP is transferred to AMP by phosphodiesterase enzyme. This enzyme is the one inhibited by milrinone, so it will cause increase of cyclic AMP and increase the intracellular calcium. So it's just a different mechanism. This one or the catecholamines act on the receptors, but this one acting on intracellular. Okay, it's an inodilator. As I told you, contractility is good. Decrease SVR, decrease BVR. We can sometimes they are using it as a loading dose to give 10 or 50 mic per kg over 10 minutes, or even on bypass. You can give it also on bypass. So when the patient came out, you start, it will be starting effect because early without a bolus, usually it's more dilator effect than contractility effect. Reducing renal and the boluses can cause hypotension. That's why if you're gonna use it as a bolus, give it as a bolus on bypass before weaning off. Metabolism is the same. You are using it maybe during weaning of bypass. This is بقى the part that it's specialized RV failure because it's increase the contractility and decrease the BVR. Okay, pulmonary hypertension. Okay, on pulmonary hypertension is good because it's decreasing also the BVR. Chronic heart failure, and this is one is very also nice because beta receptors usually downgrade. What is this? Most of the patient who on heart failure for a long time, a lot of catecholamines increase in the body. Okay, so the when you have more stimulus, the receptors will start to go down. Number of beta receptors will be less. So when you are using milrinone, it will not use the beta receptor; it will go direct inside. Okay, and it also has a good effect on bypass graft. Advantage, يعني usually no increase heart rate. In catecholamine resistant patient, as we said, it's good because it's different mechanism. Inhaled now, can you decrease the BVR without affecting the map and help LRV, especially women. The problem is vasodilatation, pro-arrhythmia, and the delayed reversibility. Okay, if it has vasodilated effect or hypotension, go with vasopressin better than no, because vasopressin does not have any effect on the BVR. The clinical thing I want to say, it's used in RV failure, pulmonary hypertension, as inodilator. Inhaled has this benefit of decreased BVR without systemic hypertension. Then we have our calcium. Calcium is, as we said, all the contractility and the vascular tone is by calcium. You have low calcium, decreasing contractility, decreasing SVR, hypoperfusion, and hypotension. Okay. If the hypocalcemia is less more than 0.8, usually well tolerated, minimal effect, and the moderate or severe can cause problems in the hemodynamics. On bypass, usually calcium can decrease or increase or remain stable. Variability depends on the calcium, the bypass component, if he received blood products or not, because blood products have citrate, and this citrate with blood transfusion can cause chelation and decrease the calcium. So it's better to monitor it, monitor of ABG analyzer to measure ionized calcium. And if you remember last time when we say gas, TV, and in the gas, we said all the electrolytes, and we said keep calcium more than 1. Okay, detect the fluctuation وguide calcium supplementation. Effect بقى increases myocardial contractility when you give it, and improves the MAP, mean arterial pressure, and improves the SVR. May impair diastolic dysfunction, especially in high doses. Why? يعني I will, inshallah, when I speak about the diastolic dysfunction, because it's a little bit different in its pathophysiology, but we will know why its calcium will not be good in it. Okay, so just keep it in your mind. Based on ionized calcium, if a patient's calcium status is hypo, it will increase the contractility. If it's normal, it will increase the mean by SVR, no effect on the cardiac index. Typical dose, we are giving 5 to 10 milligram per kg. An adult, you give 1 gram rapid rise in ionized calcium, and the protocol is give 1 gram calcium chloride into pump before weaning. To, as I told you, increase the MAP, counter hypercalcemia, offset even if you have hyperkalemia. Caution, avoid or routine use if patient is hypertensive on cardiopulmonary bypass, or, and this is the important part, I want you to understand, if the patient goes into any ischemia, cardiac calcium at this time will increase the myocardial oxygen demand. So don't give the calcium if the patient has ischemia. Okay. Now we went through different types of neutrophils and we spoke about type. Now, let's return to the subject I have postponed from last time, which is failure to heal from bypass, prophylactic pharmacotherapy after CABG. For example, post-operative myocardial function. What is usually happen after? Now I have a patient. This patient went to CABG. After his CABG, what will happen to him? After bypass, initial phase, first few minutes post bypass, you have transient improvement function. Then we have what we call the early deterioration. From 4 to 6 hours post-operative, expect a dip in function. Okay? يعني now post-bypass, first 4 to 6 hours, usually it will be some deterioration. Sometimes it's severe, sometimes it's very mild. Okay? But this is the phases. Okay? Then you will have a gradual recovery begins after 6 hours, and usually the full recovery of the myocardium and everything usually within 24 hours, sometimes longer. Okay, but this is as an outflow of how you should imagine the consequences of the cardiac function, how it will behave after bypass on catch. Type inotropic support. Why I will use temporary support during weaning? Okay, need for short-term neutrophs. What will this? This is something I want you to know. If I need neutrophs, this does not necessarily means I have a poor long-term outcome. Okay, يعني some patient may have a nootropic support. Okay, post bypass and even high dose, and this is not indicates that this patient will not survive. No, okay, it's just saying that the post-operative ventricular function is not excellent. But if the patient, you did not escalate the neutrophs, or even you started to plateau the neutrophs and started to decrease even in a small يعني rate, this indicates a good outcome. Okay? And not all the patients with poor preoperative myocardial function require neutrophs. Some patients will go off bypass twice in good shape without any vaso active drugs and avoid overuse. Okay, prophylactically. But some surgeons they say no, 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 keep it. But I'm just telling you from the الأمانة العلمية, the scientific honesty. It's better not to use it, overuse it, yeah, the prophylactic. But don't say I told you that. Some clinical consideration. If weaning fail, what we should do? Go back on cardiopulmonary bypass and then evaluate with EPG, TE, Doppler of the coronaries. Consider بقى ايه الريت, الرhythm, prelude, afternoon, mechanical support, and then individualize your support. There is no single magic protocol. Okay, so I will think about what to give. As I told you, sometimes based on pre-existing heart pathology and reperfusion. Chronic heart disease, as I told you, he have high endogenous catecholamines and decrease for myocardial norepinephrine store, and he has beta 1 desensitization, and he has activated renin, angiotensin, aldosterone, and the indirect agent are often ineffective. So some beta 1 agonist may show plateau. Okay, this is a little bit difficult, but I'll tell you, if a patient has a chronic heart failure, this is some consideration. You are following with me? And if I have a patient, this patient has chronic heart failure. This is the one I just mentioned for you in the Millerinol. You remember here, where is the Millerinol? Come Millerinol to Baba. لا, this is the class. In the Millerinol, we said that, where it is? Effective in catecholamine resistance patient. Who are these patients? These are the patients who have, or who have the patients who have, yes, who have chronic heart failure, because chronic heart failure patient has endogenous catecholamine high and they have beta 1 This is not desensitization. So if you give beta 1, it will show a plateau effect. You increasing the dose, no effect. Increasing the dose, no effect. Start melatonin. So this is one population. What other population is the diastolic dysfunction? Okay. What is diastolic dysfunction? Is the heart cannot relax well. So if his heart cannot relax, it will not. Uh, I don't know. Should we? Yeah, خلاص. I will tell it for you. يعني if this is the myocardium, okay, of the LV. Let's see if this myocardium is thick like this, okay, and has a scar. Yeah, this is called myocardium and has a scar. If you put here 200 mil and you put here 200 mil, this one will be expanded very nice and it can accommodate this 20 mils without significant increase in the pressure. But this one here, it's very stiff. So this 200 will suffer to go inside here and the pressure will be very much high. This is what we call the diastolic dysfunction. Means that the myocardium is not able to relax to accommodate this. So instead of receiving 200, it will receive 100. And even if the heart is ejecting 50%, which is a normal ejection fraction, the total amount going out, it will be 50 mil, right? While here in this patient, if he has 50% ejection fraction, he will eject 100. Both have a good ejection fraction. This is diastolic dysfunction, and this is no diastolic dysfunction. This patient ejection fraction 50, because ejection fraction is systolic parameter, and this one is 50. But this one have heart failure. 50 is not enough in this body, but this patient does not have heart failure because 100 is excellent for his body. And this is the one they are called, and you might see it, heart failure with reserved ejection fraction. This patient has reserved, okay, ejection fraction, but I'm not sure is it reduced or N maybe N. Oh, sorry, with normal ejection fraction. Yeah, and his ejection fraction is fine, but he has heart failure. Why? Because the heart is not dilating enough and not receiving good enough in the diastole. Okay, this patient usually it's difficult to wean off bypass. Okay, it's common on this. Okay, I will, inshallah, when we speaking about these types of surgery, we will say how to wean with it. But if you have a patient with diastolic dysfunction, as they say it's severe with restrictive valve, yani prepare that this patient will not be easy to go out of bypass. Standard myocardium, usually we are seeing it post bypass, post ischemia, reversible myocardial dysfunction. Normal perfusion, normal everything, but as if the myocardium is hanging like your laptop is hanging and you need to restart it. Okay, so they call it the standard myocardium. Maybe he's still as if the myocardium did not wake up yet from the what we can call the effect of the cardioplegia. Okay, although everything is fine, but he's still sleeping. Okay, so positive effect indicate adequate ETV, and usually it responds well to electrode. And the difference between stunned or active ischemia, if you give support, this stunned myocardium will, as if you slap him on his face, slap the myocardium on his face. Wake up. He said, yes, okay, okay, I'm fine. But if you slap him on his face and does not respond, خلاص, this is active ischemia. This myocardium is in the long bypass, long bye-bye. Okay. Now, if a patient has some RV failure, okay, what we're gonna do? Optimize oxygenation. Okay, reduce RV after load by oxygenation and decrease the CO2. So after load or pulmonary vascular resistance will be fine by treat acidosis. Okay, and have low VO2 is not good. We need good VO2 and we need no CO2 to normal. صح? All of this will affect the pulmonary vascular resistance. Should we increase the CVV? No, make it low. Why? Also because it also affects the VVR. Then what we're gonna use? Melatonin, our first choice. And if we use epinephrine, please, in very small doses. okay, in a very small doses. Or isoprenaline is very excellent also. When I joined cardiac anesthesia, milrinone was not invented yet. And usually, if you are lucky, you will have isoprenaline in patients with high pulmonary hypertension. Otherwise, we give a very low dose epinephrine, and we sometimes we put GTN with epinephrine just to make sure that it has a combined effect on the PVR. But isoprenaline has an excellent effect on PVR to decrease it and help you with the RV and the milrinone also. Okay, vasopressor like noradrenaline, as I told you, it has some books that we can use it, we cannot. Nitroglycerin, GTN also, but it will cause also systemic. Okay, or we can go for pulmonary vasodilator like nitric oxide or ibuprostenol, okay, or BG1 اللي هي prostaglandin E1. And خلاص you cannot بقى put him on mechanical ventilation. Now you are familiar with everything I'm saying here. You know the milrinone, I told you about the epinephrine, different doses, isoprenaline, norepinephrine, okay. I did not speak about nitric oxide, but I will, inshallah. But I tried to concise the amount of the drugs I speak about. So this is patient with RV failure. LV failure. Dopamine. Who will use dopamine? Whoever want to use dopamine, raise up his hand and get out of the lecture. And join any cardiology people away from it. Epinephrine, dobutamine, milrinone, all of our nice things. Usually with the dobutamine, we might add norepi, okay, and the milrinone also we can add norepi. If we are afraid about the pulmonary hypertension, you can add vasopressin, okay, just in case. You can also, for the LV, can I use intra-aortic balloon? So I'm not using it for RV, I'm using it for LV. Why? Because it's intra-aortic balloon pump, okay? And inshallah, I will make a lecture, a whole session, inshallah, about the mechanical support, okay? Or that, as we said, like the RV, your last chance is the video assisted diastole. Ventricular assisted devices. Here also you have ventricular assisted device. This is bad. The last thing I wanted to finish with. It's some scenario you are facing post bypass. Now we've spoken about different scenarios of so for those who get lost from me. Now we're speaking about weaning, okay? And in the weaning we spoke about how to support, how to wean, and in the trope selection consideration. What we are using is specific scenarios, like patient has chronic heart failure, patient with diastolic dysfunction, patient with standard myocardium, RV failure, or LV failure. Okay. Now there is also some syndrome we are facing post bypass is low after load vasoplegia. Okay. The vasoplegia is a syndrome. What is the definition? Go here. You have a low map, and the cardiac index is excellent. And when you give noradrenaline, patient improve. So it's not a prelude, it's not contractility, it's not heart rate, it's just severe decrease in the SVR only. Okay. Strategy are using norepinephrine, epinephrine, vasopressin, methylene blue, phenylephrine, whatever. Okay. What's the pathophysiology? Severe hypotension, decrease SVR, decrease arterial responsiveness. Incidence 10%. Who I should anticipate? Patient with ACE inhibitor, especially those who took it in the morning. Of course, diabetes, low ejection fraction, normal. Well, yeah, and a lot of risk factors. Not all these patients. Sometimes you have a patient who has all of these, and eventually nothing happens for him. And sometimes you have an excellent patient and he end up with vasoplegia. So it's just the risk factor. Prognosis, and it's not excellent all the time. I will go here with some vasopressors, okay, for the sake of the, and I did not mention it with the vasopressor or with the inotropes. I kept it here when I tangle or I am handle the SVR. So these are vasopressors. The first one with noradrenaline we spoke about. Now we have the phenyl. Phenyl selective alpha 1 agonist cause more arteriolar than venous vasoconstriction. Transient preload increase. How? Hepatic and splenic vasoconstriction help you with the return, venous return, and the no beta. So it's increase the preload, nothing on the contractility, reflex brady, and this is very significant in phenyl. Increase SVR, increase BVR. Okay. So this is the first thing. It's a vasoconstrictor, but it will help also. One, two, three, four. Keep it in your mind that it's a vasoconstrictor, but it will increase the preload, will not affect the contractility, will cause the reflex brady, and it cause also affect increase the BVR. We are using it as 50 to 100 mic, even to 200 mic as a bonus, no problem. Okay, or you can use it in fusion, yes, from point one to two. Okay, so I can use it as an infusion or I can use it as a bonus. Very nice onset and good duration. All of this nonsense, don't care. Low SVR, we are using it as I said. Temporary basing, bridge, sorry. Aortic stenosis, usually it's very nice to use it with patients with aortic stenosis because it will increase the MAP, increase perfusion without tachycardia. LVOT obstruction with SAM, it's excellent, and we will know why when we spoke about this one. Component of pharmacological balloon pump with nitroglycerin. I don't know this. What's the advantage? Short acting, yes. Easily titrated, yes. Predicted, very nice. Redistribution of the blood to brain, heart, kidney, maintaining MAP. Disadvantage, reflex brand. This is very dangerous, especially if the patient already brand. Sometimes you get patient, his baseline heart rate is 50. You start to give him repeated bolus. He end up with 37 heart rate and then ventricular arrhythmia and go back for cardiovert. Okay, may decrease the stroke volume, cardiac output due to increase the afterload if you have poor function, of course. Increased BVR, as we said, risk of poor splenic renal extremity perfusion in high doses, of course, and less effective in profound hypovolemia. Okay. Out of all of these, was the takeaway home advice? Phenyl is reliable, okay, with low heart rate, but caution in brady and pulmonary hypertension. It stabilizes the MAP, but can impair cardiac output and tissue perfusion in high doses. Clear? Right. What is the other one? Vasopressin. It's another drug. It's endogenous, and it acts on V1 receptors. Potent vasoconstrictor. Okay, as we said, this is the primary one. Okay. But what about its effects in the preload? Nothing. What about the contractility? Nothing. What about the BVR? Nothing. But can cause some reflex decrease in the artery. So can I use it as a bolus? Yes, you can use 0.5, يعني half unit or 1 unit. Or continuous infusion, zero point zero 0.04. Usually we start with 0.02, maximum 0.02. We never reach 0.1. Clinical uses, the same way I just say about. Advantage, no increase in the BVR, easily titrated. Decrease the incidence of AKI. A lot, but now you will, if you go online and search for comparison between noradrenaline and vasopressin, يعني massive amount of research comparing both, but don't bother yourself. Disadvantage, sometimes the pressure is unpredictable, especially with bolus. Okay, so make sure if you use a bolus, don't get too much. Can decrease the same splenic hypoperfusion. This is something we saw a lot in all the patients, especially. This is something to keep in mind that it can cause gut ischemia, especially in older patients. What is the thing? This phrase to put in your pocket? Highly effective in vasopressin and in pulmonary hypertension, especially norepinephrine is not adequate and you cannot use it because BVR is high. Clear? Evidrine. I would not speak evidrine. Everything is evidrine, and you know we use it most of the time as boluses, never as infusion. Actually, it's used in open heart is very limited. Uh, because يعني you can use it in regurg lesion because also you are afraid of its heart or fast heart rate. So it's indirect beta agonist suitable for bradycardic hypotension with low contractility. Okay, avoiding dynamic LVOT obstruction definitely because it affects indirect beta agonist. Okay, and we will say in HOCM in aortic stenosis where tight blood pressure is adequate. Okay. Then, to finish this extensive lecture, these are drugs I just want to mention it for you. There is a lot of things now about using it in sepsis or in patients with refractory vasopressin. Angiotensin 2, Okay, you know we have angiotensin 2 receptor. So you are using the angiotensin by itself. Okay. What we want to say, it can use in refractory vasoplegia. Okay, when you reach your limit on noradrenaline, but if you are, yeah, it's very costly and it's not available everywhere. Can we use hydrocort? Some say yes, some say no. Okay, sometimes it give a good reaction, give 100 to 200 milligram hydrocortisone. Okay, In- and sometimes it give, as you said, it's inexpensive, available. Really, sometimes it have a good effect, but as I told you, the drawback, take care because it can cause hyperglycemia. Okay, so use the shock with suspected adrenal, especially when pressors are in effect. Nitric oxide scavengers, okay, and also now massive amount of papers nowadays comparing methylene blue and hydroxycobalamin in also the vasoplegia, because they said in vasoplegia the problem is regarding nitric oxide. So some drugs like methylene blue and hydroxycobalamin, this vitamin B12 by the way, can cause scavenging in nitric oxide and improve the outcome. We have used methylene blue a lot. It's 2.5 milligram per kg IV, and you will find that the urine change will change for this patient. Okay, the methylene blue. You should also follow up his HBG for methemoglobinemia. As I told you, we are using it as adjunctive in vasoplegia. Okay, and that gives a good results. Yeah. Hydroxycobalamin, you give 5 grams, which is a huge dose, by the way, over 15 minutes, and they say you can repeat it. Yeah. Anyway, for now, there is debate. Should we use it? Should we not? I just mention it for you, and I keep it here for notes for you who want to read more about it. Okay, usually it's a last line agent when you give catecholamine and you give vasopressin and you give everything and still vasoplegia is there. You can go for either one of them, either cyano hydroxycobalamin, cyano or to go with methylene blue. Okay, that's all for today. I tried my best to keep it all in one lecture. وجزاكم الله خيرا والسلام عليكم ورحمة الله وبركاته.